Hello, everyone, and welcome. Welcome to session one of our two-part Blackford Analysis Breast Imaging AI webinar series, Staying Abreast of Progress. I'm Lisa Bostic, Clinical Operations Specialist for Blackford, and very happy to have you join us today for what I think will be a great and informative session. So for anyone who might be unfamiliar with Blackford, we are a strategic AI platform partner and solutions provider, which means that we aim to help healthcare organizations adopt an AI strategy by offering a wide selection of AI apps through our platform and several different subspecialties, such as breast imaging. We are lucky to have a great selection of breast AI applications available in our portfolio, and it's great to have many representatives from our partners on the webinar with us today. So before we start, I'd like to quickly go around the room and let our partners introduce themselves and the companies they represent. And Dr. Garg, why don't you kick us off?
Absolutely. First of all, thank you for allowing me to be in this discussion. I am a board-certified radiologist practicing in the United States and CMO of MedCognitics, an AI-driven radiology platform. MedCognitics provides an advanced AI software platform which integrates into the radiology workflow. The AI platform is trained on a diverse global patient data set to mitigate data biasing. And we've also recently received MedCognitics has received FDA 510(k) clearance for our breast cancer screening software and triage software. I personally am a strong believer that the utilization of medical imaging will grow exponentially in the years to come, and radiologists must adopt AI to increase their own efficiency. That's a little bit about myself.
Thank you. And Dr. Trail.
Hi, again, thank you very much. This is very exciting to be a part of this discussion. I'm a practicing radiologist with University of Michigan Health. I'm a mammographer. I read mammograms yesterday, and I've also been a KOL, key opinion leader with iCAD Medical for over 4 years now, assisting them in product design and especially with adoption strategies, talking directly with multiple radiology groups around the country. I've also been a AI user for about 5 years. We got in early. I've been using detection for 5 years, and I've been using the risk algorithm now for over 2.
Perfect. And Dr. Haritzis.
Yes, thank you very much. Also for this invitation. My name is Alexander Kiritzis. I'm a physicist. I studied physics at the RWTH in Aachen, where I worked many years in the department of Professor Christiane Kuhl. Always did a lot of breast imaging there, and now I'm co-founder and CTO of the company B-Race. We are a spin-off of the University Hospital in Zurich, and we developed a software on AI or based on AI to enhance the radiologist and technician workflow explicitly for breast imaging. We cover different modules there, like density assessment, but also quality assessment according to the different standards which are distributed all over the world, PGMI, PAI, also EQUIP. And also we have a diagnostic module in which we can classify lesions, microcalcifications, or any kind of opacities according to the BI-RADS catalog.
Wonderful, thank you. And David Lai.
Yes, yeah. Hi, my name is David Lai. I'm the Technical Sales Director at Clarify. We are an AI medical imaging solution company that specializes in disease detection and reporting solutions. So we have a ClearSigma, which is a breast density assessment solution that's already been FDA and clear and also CE marked. But our company also, another area is the radiation and contrast dose reduction solution.
Great. And then Jessie Allen.
Thank you. I'm Jessie. I'm our Senior Product Manager at Densitas. We provide operational AI to drive breast cancer screening efficiencies and workflows. And this includes algorithms for breast density and image quality that feed our overall platform for quality, compliance, and analytics.
Great. Thank you, partners, for the introductions. Well, we've got a full agenda today, so let's get right into it with our first topic that I'd like to talk about, which is density assessment and the upcoming FDA legislation that will require density to be included in the report that is sent to patients following their mammogram. So at this time, mammography facilities are required to provide patients with a report that explains the findings of their mammogram, but it is not currently federally mandated that this report includes information pertaining to breast density. But on September 10th, 2024, changes on legislation will require that this information on breast density be provided to patients within this letter. Information like whether or not the patient has dense breasts and implications of having dense breasts, like an increased risk for breast cancer and increased difficulty in cancer detection with dense breasts. So there's a lot of conversation around the effects of this change on US mammography patients. And I'd like to hear from our partners their thoughts on this upcoming change. So if you wouldn't mind starting us off, David, how do you think the new legislation is helping women's chances to diagnose cancer earlier?
The recent amendments to the Mammography Quality Standard Acts of 1992 is to modernize the law according to the latest science and best practices in breast cancer screening. So one of the key updates is the requirement for facilities to notify patients about their breast density. The updated regulations will make breast density reporting consistent for all patients in the country. And so currently, approximately half of women over the age of 40 in the US have dense breast tissue. So the dense breast tissue can make cancers more difficult to detect on the mammogram. And additionally, denser breast tissue in a patient is associated with a higher risk of developing breast cancer. So by promoting patient access to information, such as specific language on how breast density impacts the accuracy of mammograms, this allows patients to make the informed decision about additional screening options, such as 3D mammograms or ultrasound or breast MRI. So these options can detect cancers that mammograms might miss. So we can have better breast cancer prevention and early treatment.
Thank you, David. And Dr. Garg, do you have any additional thoughts on the new legislation?
Absolutely. I think it's great that this legislation is being passed. It is, as you mentioned, much more difficult to diagnose smaller lesions, be it nodules, calcifications, et cetera, when a patient has more dense fibrous tissue. That being said, with this, with the density with the report, both the ordering clinicians as well as the patients are going to be able to see that, and together they can make the decision whether or not they need to seek alternate means of evaluation, be it ultrasound, mammography, et cetera, to see if there's any smaller lesions that are being missed. With those additional screening modalities, I think that additional smaller lesions will be picked up and diagnosed sooner, treated sooner, and will overall have better outcomes. So I think there's going to be some greater reduction in terms of the number of treated cancers that have bad outcomes.
Great, thank you. And next, I'd like to ask our partners about how this change might affect the radiologist. So do you think that this legislation change will affect the radiologist workload? And if yes, how so? Dr. Karitsis, what are your thoughts?
Well, thank you very much. It's a very good question. Yes, I definitely think it will, of course, change the radiologist's workflow in actually many ways. First of all, I think it's good that there's a transparency towards the patient and the patient gets informed about the density to further plan subsequent imaging modalities, for example, as has been said before. Of course, this will also increase the workload in case of conversation of the doctor to the patient. It needs to be explained. What is the density? What does it mean for the patient? What comes with it? But what we also see, especially in Europe, is that based on the density assessment, you might also think of stratified screening strategies for certain patients which have maybe an increased density, which was assessed, and then do a more personalized screening approach to densities with to patients with a higher risk, which is very often correlated, of course, also with the density, towards patients with a lower dense breast. And this can also be something then at the end which will facilitate the workload of the radiologist and of the doctor to have really a personalized screening approach there per patient based, for example, on the density assessment. But for that, also the density assessment needs to be classified in a standardized way. And there, I think AI can be a great companion to do that and to prohibit that.
Thank you. And Dr. Trail, do you have any other thoughts on this?
I do. So we've been reporting density for a while. I'm glad that the government is stepping in. That seems to be how things get done on a large scale. So, and I think the requirement that it be simplified to you have dense breasts or you don't have dense breasts is good messaging for the patient. We've been reporting it with the classifications all along, but that simplifies it. Density is one risk metric, so it's somewhat similar to age. It's used in many models as a contributing metric. So it's obviously good to know that. I think I'm very pro patient empowerment. I think the patient needs to know, which is a huge step by this, what their risk is. Women are busy, they have families and jobs, and they need to know this. And I think that's the best simple application of it now. There's still questions, what do you do? There's no widespread agreement or standard guideline as to what you do next with these patients with this one elevated metric. So the discussion then gets personal, and honestly, everybody kind of has their own risk tolerance. So it definitely empowers a patient with actionable information that helps them decide what to do. And it's a contributing metric to other even more accurate risk models that would include, AI scores, change in AI scores, age, genetics, family history, et cetera.
Great, thank you. And I'd like to ask then, how can AI help ease the added pressure of the new requirements or even pressure on the radiologists in general? Jesse, what's your perspective on this?
Thank you. AI can streamline the process of breast density reporting by automatically assessing and even pre-populating mammo reports with that breast density category. And that can save radiologists time in ensuring consistent and standardized reporting as well. While the time saved per report itself may be or may seem minimal, it does add up across reports. And also the standardized AI assessments can reduce the variability of visually reported density as well. So it can really help in ensuring consistent and standardized application across all patients year over year, which is especially important with the information being communicated to the patients. If it's changing year over year, that can be really confusing to them. The other thing is using AI to standardize these assessments can also help ensure the right women are identified for supplementary screenings to reduce both false positive and false negative results.
Very interesting. Thank you. And what about you, David? Is there anything you'd like to add?
Right. So the breast density notification law is designed for the betterment of patients, certainly, but it also adds another layer of the complexity for facilities. So AI certainly offers advantages in easing this pressure. So one example would be AI can analyze mammography images to perform breast density calculation accurately and quickly, free from human perceptual bias. So this will minimize variability and subjectivity in mammography reporting. And so the generated report can include the breast density information and language, ensuring compliance with the new FDA requirements. So that will be one of our solutions that we do with Clara Segment internal reporting. Other AI can also help optimize workflows by prioritizing cases based on those with a higher breast cancer risk, such as patients with denser breasts. So this can ensure the high-risk patient receive timely attention, resulting in enhanced quality of care. So in general, I guess the AI is useful in streamlining and automating the workflow in meeting the new requirements, leading to better health outcomes for patients.
Now, we'd love to hear about each of our partners' products and what they do, but as we're limited on time today, I'd like to ask Dr. Trail for a quick overview of, in general, how AI works and what kinds of things it can do within breast imaging. Dr. Trail, could you tell us about what AI can do?
Sure. So there's multiple functionalities. One, we've been talking about density, and really this is the only way to be consistent. There's just way too much variability in human reporting. An individual can change from year to year with what they describe. So we've been using the density that iCAD provides us for a long time now, and it's our standard. Then the other functionality is detection. Those are communicated to the radiologist in two main ways. One is a score. You get a case score or a lesion score, which is the likelihood of malignancy. And then you also get a case score, which is a global application of that risk. So what I found personally, and with talking to radiologists, you really need to understand how those numbers distribute and what they mean. This is a new path for radiologists. It's math, it's a number, and there's a scale, and you need to know what a high score means in terms of how much human input is needed to come to the right decision versus a low score, where the requirement for human input is not as high, and sometimes the functionality of the algorithm approaches almost being autonomous. Risk is another developing functionality, and this is something that I've been particularly interested in. What the risk functionality does is, again, it's a mathematical measurement that gives a score on the current study of the likelihood of this patient developing cancer in the next 1 year. So versus the most common existing models, which are based on family history, patient questionnaires, giving a lifetime risk, this is a much more actionable number. It gives you insight into the next 12 months, what you might want to think about doing. It gives the doctor a much more actionable reference. And I recently presented a paper that shows when this score changes over time, that is an additional risk factor that looks to be very promising. So it doesn't mark anything on the images. It just gives you a mathematical score. And that's what you use with to discuss the patient's risk with them.
Thank you, Dr. Trail. It's really incredible what a wide variety of tools we've got to provide to radiologists. That's impressive. Moving on to our next topic, we'd like to spend a little bit of time talking about image quality reporting. And when we talk about image quality, we're talking about the quality of the actual mammogram. So was the patient positioned correctly? Was all of the necessary anatomy included? Were the exposure factors set correctly for appropriate density and contrast for detection? So I'd like to ask Jessie from Densitas, why is quality important, and why is it important to flag dissatisfactory quality images?
Great question. Flagging poor quality images is crucial. But I like to focus on quality as so much more than that. And I really see it falling into two categories. So the first one is clinical, where flagging those poor quality images is really crucial. To ensure good quality images is really important, because poor quality mammograms can result in up to an 18% reduction in sensitivity of mammography. So it comes down to, if you don't have a good quality mammogram, you increase your likelihood of missing the cancer. It's a case of garbage in, garbage out, for people who are familiar with that in AI. And this is true whether your radiologists read with or without CAD software. It's also important, as poor quality mammograms can lead to technical recalls, and identifying these mammograms early before they trigger a technical recall can avoid those unnecessary recalls and minimize patient anxiety as well. There's also an operational side of quality, where it's really about having that quality assessment on every mammogram. So you can, yes, identify those poor quality ones when they pop up, but also easily identify the best quality ones for ACR accreditation, drive broader quality improvement initiatives, and track performance in a way that can only be done when you measure quality against the same ruler for everyone.
Thank you, Jessie. And Dr. Kairitsis, do you have anything you'd like to expand on?
Well, I completely agree with what has been said before. I also want to add that the quality assessment as I said before, it's very crucial also to have only good quality mammograms, of course, and well-conducted quality mammograms in the workflow of the radiologist in order not to miss any cancer. So features like, is the whole parenchyma depicted in the lateral and the medial part? Didn't you miss any part of the tissue? This is actually the most important part of the whole quality assessment, to really depict the whole breast. This is what it's all about, right? And all those different features we are looking at to assess the overall quality actually tailor towards that topic, depict the whole breast. This can be then measured with different features. At B-Race, we measure more than 16 quality features, all with dedicated AI algorithms. And I think what is also very important is, and what we are also trying to do and accomplishing with our software, is to give a direct feedback to the radiographer on the quality assessment, and not only if it is a good or a bad image, or a perfect, good, moderate, or inadequate image, depending on which scale you are working, but also what has been done correct and what has been done wrong, so that if a retake is being triggered, the technician knows exactly, okay, I need to adjust there. Maybe I need to pull the breast a little bit more, or maybe the elevation of the breast was too high. So to have a direct action and work instruction based on the outcome of the AI. And furthermore, I would like to address that quality, especially again in Europe, is a very sensitive topic, and you will also have to make sure to have a quality assessment tool which is legible to all the different quality standards which are in Europe. All the different countries use different scales. There's PGMI in Switzerland, for example. In the Netherlands, they stick to 2 classes. In Norway, they stick to 3 classes. So you have to have an adaptive tool which can adjust to any quality system in the world, which we can do. And by that, you can also be compliant to the quality standards in each of the countries when it comes, for example, to screening programs where you need to report. And also there, a quality system can take off workload of the radiologist, and all this reporting can be done by AI, providing all those measurements and statistics to the authorities to show that the quality is in the right scale.
Thank you. And back to Jesse, will you tell us how AI can help with quality and quality reporting?
Absolutely. So similar to what I was talking about previously, I see AI as falling into these same 2 categories as well. So you have that clinical AI that impacts on diagnostic capabilities. Can the radiologist use this study to appropriately report? And then there's the operational AI aspect that drives workflows and efficiencies on a larger scale. So as we mentioned before, poor quality images impact radiologists' ability to find the cancers on the mammogram, and AI enhances that exam quality over time, and it can do that immediately in the moment as well, and improves interpretation accuracy by providing consistent and precise quality assessments on every mammogram. As was mentioned by Dr. Christus, having the actionable feedback and identifying what exactly was deficient in the mammogram is crucial. And this is one of the things that we offer at Densitas. Now, mammography is a highly regulated field, making quality not just a clinical issue, but we also see it as an operational one. So AI-based image quality assessments on every mammogram can drive a number of workflows, including EQUIP and ACR. And instead of subjective and manual processes that lead to variability in quality across sites and are nearly impossible to sustain and scale, facilities can leverage operational AI and these quality assessments to drive and maintain efficient and effective processes. And this is particularly beneficial in addressing workforce shortages and expanding service delivery. I'd also like to highlight as well that using AI ensures that quality is a priority across all women, not just a randomly sampled set for EQUIP. So women, we like to say women aren't widgets. You can't randomly sample them and assume that everything in between is perfect. Assessing every single mammogram for every single patient, which is really only possible with AI, ensures the same standard of care across all women. And I'll just end by highlighting one last operational benefit, and it's from a technologist performance perspective. AI standardizes image quality assessments, ensuring consistent application of evaluation criteria across technologists and sites. So these objective quality assessments minimize subjectivity and biases and offer a fairer evaluation environment. that helps in accurately tracking and systematically improving the team's performance. And this level of quality improvement is only possible when using a consistent and objective measure across all mammograms.
Okay, great discussion. Thank you both. So let's move on now to our last topic for today's session, which is study triage. And when we're talking about triage and breast imaging and AI, we're talking about reordering studies on a radiologist's work list based on AI findings. So a study that AI suspects has a positive finding would be increased in priority and interpreted sooner than a study that is believed by AI to be negative. So Dr. Garg, will you please tell us how a triage feature like this can help radiologists in their day-to-day work?
Absolutely. So MedCognetics, we have this program that essentially triages the more concerning suspicious cases earlier on, so we can read them earlier on. I've been practicing for 10 years now, or close to 10 years. And, over these years, the volume of cases that I have had to read has increased exponentially from year to year. I get tired as the day goes on, just dealing with the number of cases that I'm dealing with. And, that being said, I hate to say it, despite my best efforts, things are probably being missed later on in the day. So with the software, radiologists can focus on those cases with suspicious features earlier on first to ensure more timely diagnosis as well as treatment. Furthermore, those cases that are suspicious can be sent to those who are fellowship trained breast radiologists for greater scrutiny. And lastly, these suspicious cases can be interpreted when radiologists have a longer periods of uninterrupted time and increasing accuracy. So long story short, I think that with the triage tool, we're able to look at these cases, these more concerning cases earlier on with fresher eyes.
Interesting. And what about you, Dr. Trail? Is there anything you'd like to add from the ICAD perspective?
Well, I thought those comments were spot on. Your day is dynamic, your fatigue level varies, and I think right now, and I can tell you this from personal experience, there's a big shortage of mammographers, and it seems like every department I talk to is short. Every department has a backlog that's building. We've recently had a transient episode where we were 10 days plus behind on even looking at the screening exams. And not only do you want to get the patients who have the malignancies up to the front of the queue, and again, some of the preliminary risk studies are looking like we've got a real good metric for that. But as far as patient satisfaction goes, let's say the patient does get diagnosed with the cancer, her study sat around for 10 days to begin with, and everything downstream from that gets delayed. So I just think it's intuitive. It's just logical that you would want to have some idea what you're going to be opening. And also, I'm 66. I get tired about 1 o'clock. Okay. And any kind of control that I can have over my day is going to help me. So being able to open a case with some anticipation rather than like you're opening a present at Christmas and trying to find out what's on the other side, it's just a control issue that decreases your stress, makes you better able to manage your day.
Great. So it sounds like really beneficial for both patients and radiologists to use something like worklist prioritization.
I think so. I think it's just intuitive. I think it's pretty logically intuitive that it is.
Great. And my last question for today's session is for Dr. Garg. If you could please tell us how that prioritization works, what data points does AI use in order to prioritize studies on a work list?
Absolutely. So much like human radiologists, the AI uses specific visual clues to detect the cancers. These visual clues include overall tissue density, calcifications, asymmetries, distortions, and other soft tissue lesions. The AI also picks up on subtle image patterns related to the patient's age, ethnicity, and other hidden factors that determine the general risk of developing cancers. And lastly, the way in which these different factors are extracted and weighted is determined through a purely data-driven process. So those are some of the reasons that the AI is able to calculate the risks.
Wonderful. That's great information. Thank you for that. Really, our whole session has been full of great information, and we have more to come in part 2 when we'll talk about the role of AI in computer-aided detection and risk evaluation. So we'd love to have all of you join us to explore those topics with our partners. And I'd like to thank all of our partners for spending time with us today and all of you that have attended the webinar. We really appreciate you taking the time to learn more about how AI can help your organization with breast imaging. And if you have any questions or would like to talk with the Blackford team about your individual AI needs, please reach out. We are here and we are ready to help you achieve your goals. And with that, thank you again to all, and we look forward to continuing the conversation.